Welcome to the Coping Podcast, where we share strategies for coping with the stressors of life, especially the difficulties of parenting. And here is your host, Dr. Lee Weiss.
This is Dr. Lee Weiss. I am the host of the Coping Podcast, where I feature top experts on topics like raising healthy children, parenting, and so much more. Past guests include therapist Dr. Colleen Sierra, dietitian Lara Fields, and many more. Before we got into today's topic, I wanted to introduce our guest who I met when we shared an office at the Family Institute at Northwestern many moons ago. Dr. Froum is a licensed clinical psychologist. And of course, I admire her because she earned her doctorate from the University of Michigan. Go Blue! She did her research and clinical training for her dissertation on how children, adolescents, and their parents cope with stressful experiences. After her fellowship in Michigan, she joined the staff of the Family Institute at Northwestern, where we met, and she's been in private practice in Skokie ever since for about 12 years now. Please check out her website, www.froumhealth.com, which is spelled F-R-O-U-M health.com.
Just a quick disclaimer, the information provided is for educational and informational purposes only. This is not intended to provide mental health treatment and does not constitute a client-therapist relationship. The information provided is not a replacement for being assessed and evaluated by a licensed professional and is not intended to replace mental health or medical advice.
So thank you again, Dr. Froum, for being here. We spoke a little bit ago about one of your areas of expertise, which is treating children with OCD, obsessive compulsive disorder. And I'm so glad that you're going to share with our parent listeners more about what this looks like in kiddos and what parents can do. So I'm hoping you can start by just maybe telling us what OCD, looks like in children, and even how, what the O and the C and the D stand for.
Sure. So thank you for inviting me. Okay, so OCD is an anxiety disorder, but in the diagnostic and statistical manual, the classification system, it actually has its own category, OCD and related behaviors like skin picking, excoriation disorder, trichotillomania, the hair pulling, body dysmorphic disorder, because all of those things, there are more as well, have in common the obsessions and the compulsions. But it's important to remember, and might be pretty obvious to parents whose kids are struggling with it, that it is an anxiety disorder. Okay, there's overlap as well with emetophobia, the fear of vomiting, which is always fun to talk about, and tic disorders. So good to know too. So obsessions are unwanted, intrusive thoughts, images, or urges that cause significant anxiety. Compulsions are behaviors, rituals, rigid rules to alleviate that anxiety that are, and these behaviors, the compulsions, are excessive, they're exhausting, they're time consuming, and sometimes they can be pretty bizarre.
Right.
So that's the definition for adults as well.
Right.
And, there are many forms of OCD, and it can be a little bit like whack-a-mole. Within the same person, you can see it manifest in different ways. I don't know if you'd like me to chat a bit about that now.
Yeah, I was happy to ask for some maybe common examples of, different ways that OCD might manifest.
Sure, and there can be crossover with sensory issues too, in the area of clothing or hair or food. So something for parents to know too. And I will say that when I am sitting with a child or a teenager with OCD, that they talk about how they have to do certain things, like maybe wash their hands over and over again, or arrange their hockey bag or their dance bag in just the right way, or say an elaborate prayer at night to keep their family members from becoming ill. So this is not something that they want to do.
No.
It's not like a superstitious behavior, right? So you won the first playoff game when you were wearing your orange socks, so you're going to wear them for the next game to bring you good luck.
Sure.
right? Or you're going to avoid walking on the cracks on the sidewalk or under a ladder. Those things are kind of short and silly and fun.
Mhm.
OCD is much more serious, and it is a struggle, and it's no picnic for the person who is dealing with it. They don't want to be doing these things.
And the urges that you're describing that I have to do, fill in the blank, are causing some dysfunction and pain for the person.
Major distress, and we'll talk about when parents should be concerned, and they can kind of entangle the whole family. There can also be significant emotion dysregulation involved because it is so distressing that their brains are consumed by these obsessions, and oftentimes their rituals are being thwarted, right? By a parent, by a sibling, by a teacher, whereas these people have no idea what's going on internally for that child.
Right. So inside the child's head, they have to do X, Y, and Z. But if a parent or a teacher isn't allowing them to do that, they may have a temper tantrum or something.
Right. And the adults really might have no idea what is going on for the child, because it can be really hard to articulate what they feel they need to do. There's also a confusion component, shame, or embarrassment, those kinds of things. So,
adults will say, I know this sounds crazy, but I have to, again, fill in the blank.
Right, exactly. And kids will say that too. I know this is going to sound really weird, or there's something wrong with me.
Sure.
And one of the reasons that I really enjoy treating OCD, Lee, is because people come in such distress, and this is something that is treatable.
Right.
And it's not a quick fix. It's not overnight, of course, right? But people can feel better. They can learn to manage it and keep it contained, keep it from interfering in their lives.
And I like that, because it, again, feels out of their control. It feels, again, kind of crazy inside what they have to do, but there is lots of good research on treating OCD and a very specific type of treatment. So again, it does feel like there's hope once they find their way to you, and once they find their way to a practitioner who knows how to treat it.
Exactly. And fortunately, there are many of us in the Chicagoland area and really across the country. And I know at the end, we'll talk about some resources, but, you and I were sort of joking about, as we get further into this podcast, what we describe as far as the treatment is not necessarily something parents should try at home. There are certain things that are helpful, and then other things that are unhelpful, that they can engage in, but that with the exposure and response prevention, it is best guided by a knowledgeable, well-trained therapist.
For sure.
So, okay, I think I interrupted myself in terms of the different ways OCD can manifest.
Yeah, like I think you had spoken to me earlier about germs being a common one, but maybe you can give a couple examples, sort of like the families in which these behaviors manifest.
So there are the germ contamination, right? Pretty common, especially among kids, and in the aftermath of COVID, right?
I mean, that was even before COVID, right?
Right. Well, so I said over and over again to families I was seeing during this time with the germ and contamination type, listen to the CDC, not OCD, right? In terms of, the rules to follow.
That's
okay.
Great.
So there's also one that I see quite commonly, and not just in kids, but, teenagers, adults, is the just right symmetry, evenness manifestation of OCD, needing things to be or feel or look a certain way or just right, or to experience a sense of completion.
And would this be like tapping your pencil 3 times on the left and tapping it 3 times on the right? Something like that.
So I remember from years ago, this boy that I saw, and he would get into the car on the passenger side, his right leg would hit the door, and then he felt this overwhelming urge that his left leg needed to touch the door too. And it was this whole ritual and quite upsetting for him. And there are, numerous examples of this. So, and we can chat about that too. And there's also, this one is a little bit trickier to understand, both for parents and kids. And it's also quite alarming to the people who are experiencing it. And it's called bad thoughts OCD. And so what I mean by that, again, many different ways that it can show up, but maybe where a child is having mean thoughts about a friend or a family member that they really like, or they are having thoughts about wanting to harm these people. And again, this is just the OCD. And then it can also be worries that they did something that hurt somebody or got them in trouble. They can have thoughts about having, cheated or sworn or lied, or that they will do that in the future. And there's also an aspect of it that can be sexualized thoughts. And this is absolutely mortifying to kids, whether it's about a teacher or a babysitter or a classmate. Like, they are truly horrified and disgusted by these things. And so it's not always clear initially what is happening for them, and it takes a lot of, encouragement and gentleness and normalization for that to come out.
What? So the bad thoughts, if that's the obsession, what would be a compulsion that would kind of make that better or go away?
Sure. So that it depends on what they're struggling with in particular, but it could be confessing these thoughts and looking for that reassurance. Like, am I a bad person? Right? Is there something terribly wrong with me?
Right.
There can be over apologizing, so saying sorry for accidentally bumping somebody in the hallway.
Right.
So you see a lot of the confessing, the apologizing, and then there can be all sorts of other rituals, right? So we were just kind of describing the obsessions. There can be, for any of these types of OCD, right? And many more compulsions than I'll get into here, but checking, counting, ordering things, arranging things, repeating certain behaviors, and then again, that reassurance seeking.
Right. Wow. I can only imagine the teenager, let's say, who is brave enough to tell, his or her parents the sexual, thoughts that are inappropriate, let's say that they're thinking about, and admitting that this is plaguing them enough to get to a therapist. It's so difficult to imagine.
Well, and I've heard that even from littler kids.
Oh, yeah.
And, that as well with the thoughts about wanting to harm somebody.
Right. That too. Right.
Which they don't really want to do. But as we can chat about, the way I explain OCD to kids and families is that it is a brain trick, a false alarm, brain spam, a bully, all these different ways to think about it. It's not me, it's OCD, right? These bad thoughts that they're having do not say anything about who they are as a person. It's not reflective of them, right? So we say, OCD is weird. You're not weird.
Right. No, I think that makes a lot of sense, because I always talk with kids about, how we have junk mail or spam.
Yes, spam, brain spam. That's exactly right.
We have a little filter that takes it out of the inbox and puts it into that folder so we can kind of ignore it or delete it, but it's.
Or just let it hang out there and redirect our attention. And it's funny, I used to say junk mail all the time. How many kids and teenagers are, using email? So with the brain spam, at least they have something, or scam likely, those calls. And I'll still say junk mail, but sometimes I get these blank looks.
Totally. No, that makes sense.
Yeah.
But so it's like the brain can't filter out, right? What's kind of material we should pay attention to versus what is spam, and or what's a false alarm.
Said. It all seems urgent and important.
Yeah.
And a few points, this is reminding me of some things that I am sure to share with parents, because they're quite distraught too, generally, in those first sessions, because it's like, what is going on with my kid? So a few important things to remember, which is OCD, like you just said, in terms of that filter, it's like having a faulty enough switch. It never feels like enough, right? So, the checking the front door to make sure it's locked over and over again, or rereading the same paragraph in case you missed a word, erasing until there's a hole in the paper, right? And it's this disorder.
Is a common one too.
Yeah,
So you're
absolutely. Sanitizer, that it's a disorder of self-doubt, right? They can't ever be sure, right, that their hands are truly clean.
Right.
Or that their mom won't get cancer if they walk through a doorway a certain way.
Right. And that's interesting because going back to your burglar example, or you didn't say burglar, but checking the front door.
Right.
And I thought,
that's the idea. The intruder, someone's going to break in.
About safety, is like, if you checked one time, it'd be fine. That to me seems reasonable. But the person who can't go to sleep because they're checking 15 times and then wondering if they checked, and when they checked, was it really locked, and doubting themselves. I had not heard that before, but I like the disorder.
Yeah, the self-doubt. And I think I had read that somewhere way back. I try to cite my sources as best I can, but that this is something that, again, they can't ever feel sure.
Yeah.
And something that I also want parents to know, because they feel guilt. Like, is this something we did or we didn't do, right? That I heard this as well many, many years ago in relation to bipolar disorder, but it applies here too, for sure. It is not your fault or your child's fault, right? It is not a choice. Right. Again, they wouldn't be doing this if they didn't feel like they had to. It is your challenge to overcome together. Right. Absolutely. To work as a family, to work with the team, with the therapist, a possible psychiatrist, the school, if necessary.
Right. Oh, absolutely.
Right? Oh my goodness. It's a challenge, but no one is to be blamed for it.
No, absolutely. So when kids are younger, I'm thinking about toddlers, right? There are a lot of things they do that look a little bit obsessive, neatness and lining things up. I'm curious kind of, how do you know when it is more typical rigidity versus, again, a true blown disorder?
Okay. So thank you for that question. At ages 3 or 4 or so, what you just described is pretty typical. And so they especially have kind of rituals or rigid behaviors around bedtime, bath time, eating, right? Like they don't want the food to touch on the plate, or they, want all of their stuffed animals to be lined up, or their trucks or whatever it is before they go to bed, right? Or, I remember this little girl that I saw where ultimately I did make the diagnosis of OCD, and I'll get into what else we look for, but where she, at school and at home, when people were done eating, she had to push all the chairs in at the table, right? That if one was pushed back a little bit or off to the side, that was very anxiety provoking for her. But again, at 3 and 4, it gives a kid a sense of order, a sense of control. It's not necessarily problematic. Right. Okay. So where, the concern arises, and I talk about this for all disorders, as I'm sure you do too, but the frequency, the intensity, the duration, right? So how many hours are they spending on this? How often is it happening? And then the big piece is distress and impairment.
Right. Because that little girl with the chairs, if it had stopped there, like, oh, well, so she likes to tidy up the kitchen. Big deal.
Yeah. Right. That could actually be a good thing. Right.
Come to my house. It's not a problem. But once it starts to take more of a toll on the individual or on the family, it sounds like it's more concerning.
Right. And so the specifics that I give to parents are, as far as the interference with the 3 R's, the relationships, responsibilities, like going to school, maybe doing some things around the house, and recreational activities. And do the parents feel like it has hijacked the household? like OCD is driving that bus, do they feel like they're walking on eggshells?
Right.
That their child could erupt like a volcano at any moment?
Right. Actually, that's interesting, Erin. The idea that the children can erupt like a volcano or have these outbursts. Oftentimes parents will call in distress and say, my child has a behavioral disorder, we need help. And I'm like, okay, let's hear more. And often it's not truly a behavioral disorder, but it looks like that when you just freeze that tantrum. But it, like you said, it kind of stems from some of this discomfort internally.
So much more underneath the surface.
Yeah.
And, that it really is kind of neurobiological behavioral. It's all of these components. Again, nobody's fault, but it can manifest as, dysregulated sorts of behavior, especially in some younger kids who can't find the right words to explain what's going on with them. And they feel like they have to do whatever OCD is telling them to do.
Right. Absolutely.
In a word about that too, that, as with any disorder, there is a spectrum, like there's mild, there's moderate or severe, and, sometimes, by the time somebody gets to our offices, right, it could be pretty far advanced.
Right.
But other times you catch it early and, you can treat it more quickly.
Right. Absolutely. And I'm thinking about how many of these, kind of OCD tendencies does someone have if they have one versus, it takes hours to do their morning routine, their bedtime routine, all kinds of things getting in the way of functioning. That sounds more severe than if they just have one or two.
Or it can morph from one thing to another too. So as soon as we nip something in the butt, it's a whack-a-mole kind of thing. It pops up somewhere else. It doesn't necessarily have to. There's just the potential for that.
Yeah. Yeah.
Sure. The other piece that I wanted to talk about that we sort of touched on briefly, but this is so important in terms of, when to do something about this professionally, is when the family is being sucked in to the child's rituals. So we call this family accommodation. And I'll just wait until, I was going to wait until the end, but I'll just say it now. In terms of directing people to Ellie Leibowitz's work at Yale. I know you have the visual there.
Author of this book.
Yes. And his website, spacetreatment.net. And, he has some videos there, some articles. And that's a good place for parents to start in terms of, it is this sort of full-fledged OCD, and what do we do about it? So he has conducted this research now over several years that's actually quite promising, and shows that by reducing the parent's accommodation, in the child's rituals, or, that the child can make significant progress. So the whole premise is about parents focusing on changing their own behavior, on doing things differently, rather than trying to force the child to do something.
Right.
Because they may or may not be willing.
Right.
And so all sorts of ideas popping into my head right now. So I'll try to keep them straight for you and your listeners. So, he defines support as acceptance of the child's feelings and confidence in their ability to handle it. And, you'll hear me say all the time around here, it's hard, but I can handle it. Right? It's tough, but I'm tougher.
So it's tough or it's hard is sort of the supportive part of
validating.
And then, but I can handle it, and I can handle it is, giving them confidence as opposed to just, making it easier in the short term.
Right. And so Tamar Chansky, who wrote Freeing Your Child from Anxiety and another one, Freeing Your Child from OCD, as well as some other books, talks about our role as parents is to spot versus rescue. I mean, if you think of gymnastics, to be there to support, but not protect, to not swoop in and rescue.
Right.
So, in terms of some examples of accommodation, okay. So all sorts of things. So I'm thinking of families I've worked with over the years. And in one family with a teenager, the mom was doing load after load of laundry because the teenager was insisting that none of the clothes were acceptable or clean enough. Right. And so decreasing
like cleanliness or germ kind of family OCD.
Right. So you can sort of guess what the parents and I worked on there.
Yeah.
Right. And there are so many nuances here. You don't just rip the rug right under from underneath the child,
So this mother was doing, a ridiculous amount of laundry because
Yes.
I'm guessing in the short term, it was easier for her to just do tons of laundry than deal with sort of the emotional consequence for her child of not having the clean clothes.
Yeah. The blow ups, the freak outs,
but
the tears.
Ultimately not really doing her child a favor.
Oh, not at all.
In helping with the laundry.
So, and I'll say, I'm going to give some more examples because they are interesting and probably pretty relevant.
And it's probably easy as a parent. I could see getting sucked in pretty quickly and not realizing what you're doing. You're just doing like extra laundry, big deal. But once it becomes sort of so far gone, then you're going like, oh, this isn't normal that I have to do 12 loads of laundry a day.
Right. And Ellie Leibowitz interviews parents about this. And I think some of that's available on the website, and right. So something before I give more examples, just to, give people an understanding of why this is problematic, is that when we accommodate, which can be like the example I just gave, where you're participating in the rituals, or it could be modifying a routine, allowing your child to be late to school, or skipping a family get together that's causing significant anxiety, or the biggie again, providing reassurance that we'll talk more about. Every time we do those things, we inadvertently send the message to our kids that you're right. This is too hard, too scary, too much for you. It validates the worry.
Mm-hmm. So instead of sort of explaining that this is a brain spam or brain trick, it's saying, yeah, that is a valid thought. You should listen to it more.
Right. And so it's in this case, it's the OCD and the child are completely intertwined, rather than seeing the OCD as externalized, as over here as a common enemy to fight against. You're just giving into it.
Right.
And it's kind of like, a Band-Aid. It provides this very temporary, that gets more and more temporary as it goes along, this relief. And then, OCD comes back even bigger and louder and stronger, because the more accommodation or reassurance you get, the more you think you need. We talk about reassurance junkies, that they can become addicted to this.
Right. And again, it's like you're feeding the OCD instead of really shrinking it. But again, in the short term, it's, I'm sure, so easy for parents to have no idea they're doing that and that they're participating until it becomes obvious, in which case it may be almost, late enough that they're seeking counseling.
Right. So, we could spend like 3 hours talking about, reducing family accommodation, which is one of those things that parents can do even before they start more formal treatment.
I was going to say that's actually empowering, because they don't really need the child to buy in at that point. They can do some of the work themselves.
And they don't have to reinvent the wheel. Again, to reference, Dr. Leibowitz's book, he has, this chart at the back of it where they can start to identify, where am I getting wrapped up in this?
Yeah.
Okay. So some other examples, a family with a teenager where here was the crossover with food and OCD, that there was a particular vegetable that was a huge trigger for him. And so for years, the parents gave up having salad at family meals, even though they liked it.
Like even in his presence, you're saying?
Yes. Like having it on the table, having it where it could be seen would, this kid would just go through the roof, and so, you can imagine that part of the treatment was gradually reintroducing. And I guess we haven't talked about exposure and response prevention yet, getting a little bit ahead of myself, but I get really excited about this topic.
Yeah, no, again, it sounds like, in a way, it sounds so basic, which is kind of what's interesting. But as a parent, right, until you're sort of explicitly taught, my feeling is it's probably counterintuitive. Because again, you put the salad on the table, child freaks out.
Yeah.
Okay, we don't need salad tonight, no biggie,
Right.
So it feels more natural as a parent just to we don't need salad. I'm not going to pick my meal.
Right. It's not worth it.
It's not worth it. But if that happens time after time after time, and
eating the anxiety,
cannot see salad, that then we're doing him a disservice.
That's exactly right. And another example, and these are somewhat extreme. This can happen in much subtler forms.
Sure.
But where I don't think I referenced this one yet, with again another teenager, where she believed one of her parents was had some sort of contaminant inherently, essentially, and would not allow the parent in her bedroom. And this was going on for years. So besides not wanting to have physical contact with the parent, her bedroom was off limits.
Wow.
Right?
And that's a heartbreaking one.
Yeah. And, the bedroom too, it's kind of interesting, that sometimes even with just right OCD, not wanting a parent to come in to straighten up or anything like that, that again can be really upsetting for somebody. Sure. And so then, so the parent stays out.
Yeah. Oh my goodness.
I could regale you with examples, but go ahead.
No, I was going to say, and then there's the fear, one of them is the fear of something bad happening. And so I have to do X, Y, or Z chant or ritual to make sure it doesn't happen. So there's the safety family too. Yes.
Right. So, and the kids can be very convincing about the bad thing that they think will happen.
Right.
And even if parents know intellectually that is not the case,
right,
their child's distress is enough to cause them, to do what the child is demanding or insisting.
Wow. Right? So when you're working with families, are you asking them to sort of track some of these behaviors? Because again, I feel like parents do this automatically just to kind of calm the system and calm the child, and probably aren't aware, but once they become aware, it probably is easier to address.
Oh, for sure. We spend a good deal of time talking about it because it is one of those things where, again, we don't need to even involve the child in that part of it because parents can make those decisions on their own. And again, they're not doing it suddenly or without warning.
Right.
So referring you back to the book, where he spells out this plan for how to inform your child, really writing a letter about why the parents are making this new plan, because the old way wasn't working. It was making things worse. They were following OCD's rules.
Right.
Rather than empowering their child.
And it's a gentler approach than just starting all of a sudden with no warning.
Right. And again, you go gradual. So, the other important part of this, not to belabor the point, but is the reassurance seeking, because it is so common and it can be really sneaky. And so, some examples of that, right? I'm sure you've heard this too, with the child asking, am I okay? Will it be okay? Will I get sick or throw up? Will something bad happen? Am I dehydrated? Will I be late for a child who hates being late? Well, even though every single day they seem to be fine on timing. Yeah. So, and is something wrong with my breathing? Right? Will I fall on my face and dance? It could be all sorts of things, or even with the kind of just right, perfectionistic form of OCD, can I stop doing my math homework now 2 hours into it?
Oh,
you
right.
know?
Right.
So endless examples. And when it comes to, again, one of the, I think easiest things for parents to recognize once we introduce this idea and to do something about is to change or decrease the reassurance seeking.
Mm-hmm.
Right.
Or the reassurance giving, I guess.
Oh,
right?
sorry. Yes. The giving. It's the kid seeking. Thank you for catching that. So,
for sure. And is there, I guess, the ability to give one-time reassurance?
Right. So here's what I coach parents on, right? Where again, they're not going to spring this on the kid. I'll chat about it with the kid, or if I'm just seeing the parents during COVID, right? And trying to see very young new clients through Zoom with OCD was a challenge. So I did a lot of work with the parents,
Sure.
When we were all telehealth. And so having them say, that's, and again, some of this comes from other books that are out there, and that it sounds like that's OCD talking, or OCD really wants to know, right? Mm-hmm. I'm on your side. I want to make you stronger, mm-hmm. right? And better able to cope with this.
Yeah.
And this idea of, again, disorder of self-doubt. So this is really tough, what I'm about to say, is to listen to your own voice, right? Trust what you know the answer.
Right. But not having the parent give the answer directly.
Right. And there is, I will do one and done where if a child is totally frantic, right? We can answer the question once, or you can even jot it down like on a piece of paper or in a notebook so the child can reference it, because you're getting to the ultimate goal of the child not seeking it constantly from the parent.
Right. But it's baby steps to get there.
Exactly. Incremental.
I'll sometimes, in general with kids say, that's a worry question. When they're asking a question that I believe they really do know the answer to, mm-hmm. And are, like you said, just kind of seeking the reassurance. And so I'll say to parents, same thing, like, answer it once, or if you answered it every day for the last week, just be like, what do you think? Because they do know the answer. It's just they want that immediate relief of hearing it from the parent and feeling more secure.
Well, and there's interesting parts of that too. In terms of going gradual, you can abbreviate it, or, if they're looking for a certain answer, or you can give one word. It doesn't just have to be one full, reassurance giving.
Like changing up how you're responding.
So it's all about shortening, delaying, changing, slowing it down, being silly when it comes to dealing with the, exposures.
Right. This is amazing. I was going to ask, so again, parents should not try this at home, but in terms of the exposure and the response prevention, if a parent kind of identifies that they see these behaviors in their kid and they feel like they're ready for therapy.
Yes.
You kind of give a couple examples of what you do in the room, what kinds of work you do, not so that they can replicate it.
Right.
They understand what the child's work is.
Yes. And so I always, as I'm guessing you do too, sit down with one or both or multiple parents first before meeting with the child. And I even do this with teenagers up to a point.
Right.
And I don't keep it from that teenager when I meet with him or her, but to gather background information to set the stage. There's also this questionnaire that many of us who treat OCD use, the CY box, the Child Yale Brown Obsessive Compulsive Scale. And actually, sometimes that, helps ease the parents' distress because they see some of these really extreme or bizarre obsessions or compulsions that they're not dealing with.
Yeah.
Right. But then at other times, it's validating.
No, that's either way. It sounds like that's a win. Because again, I'm sure some of the ones that are a little bizarre, even the parents have shame around reporting it. It's hard.
Right. Or don't want to really know what this is because they fear the worst, right? We all tend to catastrophize a bit when it comes to our kids.
Totally.
Right. Totally. Okay. So, so I have that session with the parents and we talk about accommodation and I explain my treatment approach. And so when a kid comes in, oftentimes they do want to be there because they've been suffering so much, as I alluded to earlier.
No, it's not fun to be having to do what they feel they have to do.
Right. They are somewhat motivated and willing versus more of the resistance or stonewalling that you see in other situations. Now, you can get some of that the further you go along in the treatment with the exposures. Right. So, okay. So I explained to them, now, well, I'll back up a little bit. Oftentimes the younger kids have not heard the term OCD and they don't know what it is. And the parents, even if they've suspected it, don't use that language. And I am generally a proponent of sharing the name of the diagnosis for normalization, for validation, for relief, that there is a name and a treatment for this, but it depends.
Right.
So there are other words that I've used as well. I have said HST, habits and sticky thoughts, so, and it also, as far as rhyming, and we'll get into that a little bit too, for some of the mantras and things they can tell themselves, it's similar to OCD. You can rhyme a lot with it. But that with teenagers also, that if they're going to jump on Dr. Google, I want to make sure that they're going to reputable sites.
Right.
But more often than not, and earlier on in the treatment than not, I do tend to use that term.
Yeah, for sure.
Okay. And so we talk about what it is, as you and I were speaking about, right? The brain trick, the false alarm, the brainstem, the bully, a hiccup, right? So there's another well-known therapist who treats OCD who talks about the scare or the nonsense message and scary packaging. I mean, that's kind of what it is, that we're believing what OCD is telling us, but it's just a glitch.
Right, a glitch. Right.
So I say that too, or a blip, or all sorts of things. Right. And helping them see that this is not something that they want to be thinking or doing. Right. OCD is running the show. So again, it's not me, it's OCD. Yeah. And I'm going to talk you through kind of a couple different approaches. Again, feel free to cut me off because I could talk all day about this.
This is great.
Okay. So there is this 4-step process. Oreen Pinto Wagner, who wrote What to Do When Your Child Has OCD. It was written quite a while ago and it's dense, but there's a lot of good information in there. She came up with RIDE, RIDE. So you rename what's going on, relabel it. This is OCD, right? So, and then the I is insist I'm in charge, right? OCD, you're not the boss of me. And that's when you can get into the bully, right?
I was going to say, that sounds like where I say, this thought is bullying you. And what would you say to a bully, right? You wouldn't just let him or her run the show. So that's
right. And even more than saying it, we draw it, we name it, we act it out, we practice it, right? Totally. So again, for older kids, sometimes I'll use bully. For little ones, I might use bug.
Yeah.
Like a really annoying bug that's pestering you. So, okay. And then the D. So here is what is key to the treatment of OCD and any anxiety disorder. To quote Patrick McGrath, who treats anxiety and OCD in this area and has written a book even about OCD. He says you can't think or talk your way out of OCD. You need to behave your way out of it. And the way you behave your way out of OCD is that the D in RIDE, do the opposite of what OCD is telling you. That's the exposure and response prevention, which I guess we haven't quite named. It's like the gold standard for treating.
But you see that when OCD. You do X, Y, or Z, or you don't do X, Y, or Z, like the sky doesn't fall down. Nothing crazy, terrible happens. So hopefully weaker.
Right. And so the ERP is about intentionally doing what OCD is telling you not to do, right? Like eat the dirty grape, leave the mess of toys on the floor, say to yourself or write down, mom is going to get cancer. I mean, all these things that sound horrible.
Right. But yeah, I mean, if it's keeping you in this scared place, it's not really helping.
And then you can't do the ritual that brings you comfort. You are supposed to sit with the anxiety. And there's been this shift in the understanding of how exposure and response prevention works in the last several years, from kind of this habituation model where we get used to it and our anxiety subsides, to the inhibitory learning model where our fear response is inhibited and we lay down a new neural pathway over it. And we learn that what we expected would happen actually didn't happen. And how cool is that?
Yeah.
Right? This was not as bad, as scary, as awful as I thought it would be. So it's a similar process that we're doing, but there's a shift in the underlying mechanism as to why or how this works.
Right. That's really interesting. Really interesting. Wow.
And then the E, so otherwise you just have RID. And I guess you want to get rid of OCD, but you can also take it for a ride. The E is when you do these things, when you're able to stand up to it, to boss it back, to not engage in the ritual, you can enjoy your life. Right? Because you're free from OCD.
Yeah.
Okay. There's another kind of 4-step with it, and I integrate both of them. They're compatible. So, and we won't in this podcast get into cognitive restructuring either. But there's a more of a cognitive approach, which is, okay, again, there's no cute acronym for this one, where you relabel it.
That one.
Right. So where you step back from it, and see, okay, not me, OCD. And then, you say, okay, it's just my brain tricking me again. So I don't need to listen to what it's telling me. Right. Then the third step is, which is really true, if you did nothing with the obsessions, like with, the thought or the anxiety, it eventually would pass. So that's the third step, right? So the discomfort will pass on its own, right? If I don't engage with it, if I don't feed it, if I don't fight it, if I just let it be, right?
As opposed to trying to make it go away with such urgency. Right.
So oftentimes younger kids really like to do the bossing back.
Yeah.
But there can be more of this, stepping back, sitting back approach. It's going to pass on its own. So I don't need to do the ritual. Right. So thinking of it that way. And then the final step is, well, as long as I'm hanging out, waiting for the discomfort to pass, I might as well refocus on something I enjoy doing, something that's productive, something that's fun, that sort of thing.
Right. So, no, that's amazing. So in your office, maybe one example of a presenting problem a kiddo came in with, and some of, again, some of the work that you did with him or her.
Sure. So, boy, what to choose?
I know, you have a lot.
Well, there are a whole lot of examples. So I can give you, I guess, just a few. The other piece I didn't mention, we didn't get into the nitty-gritty of the treatment, but in meeting with a child in the initial sessions, after explaining what OCD is, you talk about how it shows up for them. Sure. And so, it was called a fear hierarchy for adults, where you start to list, okay, what is it telling you from the, most anxiety provoking thing to the least, in terms of what if you ate your snack after school without washing your hands.
Right.
So that, wherever that would fall for a child, I use a fear thermometer so they can rate where that would be, and how distressing it would be for them. And once they've done all those ratings and together with the parents, you've identified all of the places that OCD is pushing them around. You can do a fear ladder or a bravery ladder from least to most anxiety provoking, and then start to intervene with what is less distressing.
Right. So you're pushing them, but you're not starting you're not asking a kid who's scared to swim, just jump in the water.
You're following their lead. Right. Because if you start with something that is way too anxiety provoking, they're going to balk. No way. I'm not doing this.
Right.
This is crazy. I'd rather just live with this,
Right. Right.
But also what they've learned recently is you don't necessarily need the ladder from least to most. You can do a menu, right? So where you just jot down a whole bunch of these things and you can, rate the distress or not, but that they have kind of the power to pick and choose.
Right.
And if you think that they will be in over their heads, you can guide them. But I've been doing some more of like the menu approach recently.
Wow.
So, and, examples that come to mind, so many. One girl in particular, when she was probably at the end of elementary school, had this more interesting contamination fear. She was reading a book. It may have been Little Women. And one of the characters had scarlet fever.
Oh.
And she developed this fear that it was going to kind of, how did she say, like suck out of the book and into her.
Oh my goodness.
And it would keep her up at night. And she would have to wash her hands after reading. And she was supposed to just read for 20 minutes and then turn out the light, but that wasn't possible. And then even having the book in her room, it was too scary for her at that time. So we did our ladder, right? And I like to frame it, bravery versus fear. Let's be encouraging and optimistic. And so, starting out with, okay, she would put the book in a different room, like away. So it was nowhere near her. And somehow that was protective. So starting out with the book in the room. And so maybe there was something on top of it so she couldn't see it. Right. And once she could feel more comfortable with that, because it's not getting to know anxiety. Right. We all need some anxiety. Keeps us safe. It motivates us, right? The goal is never zero. But once it was more tolerable for her and she learned, okay, like I don't have scarlet fever,
right?
She could uncover the book, right? And then it's also about, okay, can I skip the hand washing part of it?
Right.
So, something like that.
Right.
And, humor, by the way, is important here too. As upsetting as it is for somebody, I mean, especially with any form of OCD and particularly with the bad thoughts, we got to laugh sometimes. And there are some of the bizarreness of their thoughts and rituals. Like, what else can you do?
Right. Oh,
and there was a little girl that I had seen, and she had many manifestations of OCD, and spoiler alert, she learned how to manage them and was doing much better.
Right.
But one in particular was she developed these fears of being poisoned. And this started to spread to all sorts of things, but I think she was out with her family. Maybe they were downtown and they walked by somebody who's smoking. And all of a sudden, there was some misfiring in her brain that she could no longer wear the clothes that she had worn that day because they were contaminated. They were now poisoned. And actually, she had come home in those clothes and sat on the couch. So now she can't sit on the couch because the poison spread to the couch, her shoes. And so in terms of the humor and bossing it back, and there's so many ways to boss it back. And, but with OCD, I win, you lose. There's no such thing as haunted shoes. That's what she was able to learn over time.
And I could see, by the way, that's a good example. I could see the parent of that child, if it's causing this much distress, being like, you know what? Right. We've tried washing it, those clothes. Clearly you're still, anxious about this shirt, let's just say. You know what? It was $5 or it was a hand-me-down. We're just going to toss.
Yes. Yes.
I mean, I could totally just see how easy it would be to think you're just being a good parent and like,
right. I'm attuned. I hear you. I see you.
Like, right. You know what? It's an old couch, and how it can really take a toll if you continue to accommodate, right? Using that word. But how easy it is. I just have so much empathy for the parents who are just like, we don't need that shirt anymore.
No, thank you for saying that.
Yeah.
I mean, the compassion for everyone who is going through
It's
this.
such a yucky, such a painful experience to just imagine, right? How they're able to deal with it. Again, especially without the psychoeducation that you're providing, right? So if a parent has never heard of this, the reassurance seeking or the accommodation behaviors, they wouldn't know. It's not a natural thing to know, in my opinion.
Right. And I also say to parents to try to let go of the guilt they have for not seeing or understanding this sooner and for feeling frustrated with your kid because sometimes they can really be a pain in the butt. OCD is demanding, it's shouting in their ears that they need to do this certain thing a certain way.
It makes you late for work. It makes you, it takes a toll for sure.
Right. So, and then just, again, it could go on with the examples, but another one. So this middle schooler with the food triggers, right? Where we would just start out saying the name of the particular vegetable. I mean,
like salad. You just say salad.
And then looking at cartoony pictures of it, right? And then writing it.
Right.
And then, so before you even get to being anywhere near an actual salad, right? Learning to tolerate the discomfort. I mean, treating anxiety is all about getting comfortable with discomfort, getting used to it and seeing that you can move through it and it doesn't have to dominate your life.
Right. And even so you got the cartoon, I'm picturing the cartoon version of like lettuce or whatever.
Yes.
And just closing your eyes and imagining that you're at a table and there's salad in front of you.
There's imaginal, there's in vivo, you can do scripts about worst case scenarios.
Eat salad in front of that client in your office.
Right. You know what? We actually didn't need to get that far.
Yeah.
So, but I mean, doing things like that.
Right.
Or there was a teenager that I also saw years ago. And she had, again, the whole smorgasbord of kind of OCD manifestations. And one of them was about cancer. And, it's being, can you write the word? Can you say the word? Like hers also had that bizarre quality that made her think she was nuts. Like if she had the thought that if she points her elbow at someone a certain way, they're going to get cancer. Or that if she exhales, if she does not hold her breath in when she's leaving the house to go to school in the morning, she's going to release all of this negative energy onto the people in the home. So it was really driving her crazy, and so getting more comfortable, was saying the word, putting her elbow up on purpose, exhaling, breathing 10 times as she's getting ready to leave the house and seeing that terrible, horrible thing doesn't happen just because you think it doesn't mean it's true or that it will happen. I say that all the time.
A thought could just be a thought, right?
That's the goal with everybody. See a thought as a thought, not as a warning, a message, a prediction, not as truth, not as fact, not even deserving of your attention.
Right. For sure. And it sounds like, both the client and the parent really has to be more comfortable allowing the client to face, these discomforts or uncomfortable thoughts instead of avoid and sort of dodge and accommodate, to get around it.
One of my other favorite quotes by Tamar Chansky, remembering as parents, I have to tell myself this, it's uncomfortable, not unbearable for them.
And I say it's uncomfortable, not dangerous, but I love it.
Yes, anxiety versus danger, like that sort of thing. And anxiety can feel like danger, right? We're not going to talk about panic attacks today, but where people truly think they're having a heart attack, right? But it's anxiety.
And it's also staying calm, as a parent when the child is getting more and more dysregulated, as opposed to getting into it with them like, oh, we have to do that. And kind of getting into the.
All right. So being that calm container. Right. So when I think about what can parents do specifically, so, tolerate their distress, right? Lisa D'Amour just spoke around here. She talks about in general, let's be that steady presence for our teenagers. Our little kids need that too. They need us to be the non-anxious presence. Even if we're freaking out inside, it fuels their fire. It feeds it.
Absolutely.
Right?
Absolutely.
Okay. And then again, the empathizing, the encouraging, the cheering them on. You're kind of like a cheerleader, right? You can do these exposures. I believe in you. You're brave.
Right.
Educating yourself about OCD, right? Don't let me forget to give some resources.
Right. No, that was my final question. This has been beyond informative.
Wait, let me say something else.
Yeah. No, absolutely.
Okay. So because there are a couple things I don't want to forget. I'll be kicking myself afterwards if I do.
We're good.
Okay. So, like I said, educating, decreasing the accommodations, as we spent a while talking about. And there is a place that you would determine with the therapist for rewards for the exposures.
So if it's really hard to motivate them to do something, on their ladder, it's okay to sort of have an incentive, you're saying.
Exactly. To sweeten it a little bit, to have something to work towards, because this is hard work. I mean, I'm sort of oversimplifying everything.
Of course, no, but of course, I mean, this sounds incredibly hard.
Right. And for parents too, like what we would do in our sessions is you don't ever ask someone to do an exposure that you're not willing to do yourself. And so you're doing these things with them, right? Like if it's touching the bathroom floor and then eating, like, do we really want to do that? No, but it shows them, look, I can do this too. I'm not asking you to do something that is actually harmful or dangerous. So if the parent's part of their work with the therapist is to do these exposures at home so that they need to join in, they need to model,
That's a really good point.
So there's not always a need for that. It just depends on the age of the child and the presentation.
But again, you wouldn't ask someone to do something that is just clearly a dangerous, then it's not really OCD. It's just being smart and safe and, again, a good anxiety.
Yes. And something that parents need to know about with treating any form of anxiety and OCD is the extinction burst, right? That with anxiety or OCD, that these things can get worse before they get better once you start the treatment, because the kids, I mean, we're looking at them like, well, how could this possibly get worse? What is going on? They're clinging to what's familiar, even if it is utterly distressing and self-defeating.
Right.
And so that's actually usually a sign that they're about to make some significant progress, right? But you need to ride that storm out and keep cheering and keep encouraging. And they will get to the other side.
So the idea that it gets worse before it gets better, or it can get worse.
Short-term pain for long-term gain kind of thing. And again, people say, can you cure OCD? No, but you can learn to tame it. You can manage it. And there is sometimes a place for medication.
That's what I was going to ask you is how many, I mean, I don't need statistics, but how common is it for you to say at some point in the treatment, I think you should have a consultation with a psychiatrist about medication versus, where it just kind of seems that this by itself does the trick?
It kind of depends how much impairment and distress there is by the time they get to me. So I can be fairly conservative when it comes to medication, but it can also be an incredibly helpful resource that everybody deserves to have access to. Right. So so generally, we start with doing the exposure and the response prevention, and decreasing the family accommodations. And if we're not seeing progress, a month, and this would be kind of like meeting weekly, which is ideal, but a couple months in and the child is still suffering greatly, or now it's shown up somewhere else and is really getting in the way, like it's school, then I encourage them to at least have a consultation with a psychiatrist. And the medication nowadays is generally an SSRI, a selective serotonin reuptake inhibitor, like what you would take for other forms of anxiety or depression. Prozac, Zoloft, Lexapro, and there's a whole bunch of them.
Mm-hmm. No, and it sounds like if it's not, in certain cases, it's necessary to allow them to do the work, right?
Exactly.
It's not like that by itself will make it go away.
No, it's pills and skills, right? But it makes their brain more receptive and more willing to what you are trying to teach them, right? And so if there is tremendous difficulty, even in those first few weeks, maybe I'll suggest it. But like that it can just kind of take the edge off and make them more able to use the tools that you're providing and follow through on the exposures.
Right. Absolutely. I mean, this is beyond, it's so helpful just to hear.
I hope so. I feel like it was all over the place.
No, I was going to say before we move on to resources, if there's anything else that I didn't ask about that you feel like parents should know, again, as sort of intro to treatment of OCD in kids.
Right. Very intro.
Feel free.
Okay. I guess this is sort of like a public service announcement, but I'm sure that you have heard people say, I'm so OCD. And as somebody who works with people who truly have it and have heard from them how much that upsets them, I encourage people to pause and be mindful of the language that they use, right? So just because you like things neat and clean and organized does not mean you have OCD. It dismisses the distress that the people who truly do have it experience.
No, that makes so much sense that it minimizes the pain that someone actually feels, right? Who's actually, legitimately going through this. So it is good. It's good for everyone to be mindful of the words they use, for sure.
And that it takes a team.
Yes. It sounds like so powerful. You can't just on your own sort of treat this, and you can certainly read books and this helps. But if it's gotten to a point where you really feel like your child actually has OCD as opposed to like, one tendency or something, that it's time to really consult a professional.
Right. And so, just to clarify too, a person might simply just have OCD without the other types. And there are many more types that we didn't get into today, like hoarding and sort of like, but among kids, at least in my practice and the practice of my colleagues around here, it's often germs contamination, just right symmetry, evenness, or the bad thoughts.
Yeah, absolutely. Right. So I was going to show, so these are the two that I really love. And actually, so this is Dawn Huebner's book, What to Do When Your Brain Gets Stuck, A Kid's Guide to Overcoming OCD. Right. And I love this because of the metaphors she uses, kind of like what we were alluding to. It just seems so much easier to comprehend, even if you're a 5-year-old, a 6-year-old, like you really get what's happening in your brain in a way that's really concrete and understandable, and also how to help it. It's also kind of an uplifting with pictures and everything.
And all her books are good, by the way. And that's something I encourage parents to do with their kids, especially during the telehealth days, that was something concrete that they could do together and really join forces, against OCD.
Totally. And then, as you referred to, Eli Leibowitz's book, he's got many, but Breaking Free of Child Anxiety and OCD is one. And then I was going to ask you for other resources, whether they're websites or podcasts that parents can look into.
Okay. So there is the IOCDF.org, the International OCD Foundation. Wonderful resources. ADAA.org, Anxiety and Depression Association of America. And there is a podcast. I think there are multiple podcasts, but there's one that really has more of adult stories. So if parents just kind of want to educate themselves, or if they wonder if they're struggling with this, there is a strong genetic component. So it is possible, or maybe a subclinical, milder form. It's called the OCD Stories.
Oh,
okay.
Great.
And so I also, as I had mentioned, Tamar Chansky's work, Freeing Your Child from Anxiety. And then there's one about OCD, but in her general anxiety one, there is a section on OCD. That's been a very helpful resource to me for many, many years.
Yeah.
And Maureen Pinto Wagner's book, that What to Do When Your Child Has OCD, that I had mentioned before. And there's also one for teenagers. And again, there are many books out there, even in the last 10 or 15 years, which is exciting. This is called Stuff That's Loud, A Teen's Guide to Unspiraling When OCD Gets Noisy by Ben Sedley and Lisa Coyne.
That's great. I love that it's for, written for teens, teenagers.
Yeah. And John March's book from years back, talking back to OCD. So, a good one too. But the parents aren't alone in this. I mean, there is, and they can see on the website, there's a huge community here.
Absolutely.
And I guess one more thing I'll say is the kids and teenagers that I have worked with over the years who come here with OCD tend to be so kind and conscientious and hardworking, that they are struggling tremendously, but who they are at their core is so lovely and so optimistic.
Right.
And when they can get on board with the treatment and they have the support of their family, they can really make great strides. It's a privilege to be able to do this work.
Right. Well, we're very lucky to have you in our area to refer to.
I could say the same to you.
Oh, thank you. But to have this niche is it's very special and needs sadly. So we're glad to be able to send people to the best. And again, I just wanted to thank you so much, Dr. Froum, for your time, for your expertise, and for sharing with our audience. And everyone,
my pleasure.
Thank you. And everyone, please check out more episodes of our podcast. Go to copingpartners.com and click on podcast and articles. And thank you, as always, for tuning in.
Thank you for listening to the Coping Podcast. We'll see you again next time, and be sure to click subscribe to get future episodes. And check out our podcast page at copingpartners.com.